Yes, of course. Okay, you can go ahead.
First of all, many thanks for the kind invitation. I'm very sorry for not being able this year to attend the Congress in person, but anyway, it's a pleasure also to be remotely connected with you. Many congratulations to Professor Tzikas for a great presentation he had. I will try not to have too many repetitions with my presentation. I have no conflict of interests. So which are my goals when I have to perform a left appendage closure procedure? First of all, I want to have a safe procedure, and to be practical, I want to have a proper anchoring of the device, avoiding potential device migration or embolization. At the same time, I want to avoid any potential damage to the LAA structure and the surrounding structure resulting in pericardial effusion or pericardial tamponade. At the same time, we have already seen it's crucial to have a good final result that actually means try not to have a residual leak. Also, minimal leak may have an impact. And this is important because this really may have an impact on long-term patient outcomes. And the safety and the efficacy of this procedure is much more important if we think that the volume of this procedure has been growing in the last few years, and maybe we have seen something in the previous presentation. We may deal in the future with novel indication, and we may extend this procedure also to other subgroup of patients. What is the real key point, key step of the procedure is to try to have a good imaging-based pre-procedural planning. We know that the morphology of the LAA structure may be very variable. There are several classifications. The most utilized one identify 4 different type of morphologies. So the windsock, the chicken wing, the cactus, and the cauliflower. But we have other morphologies that do not fit in this classification. Typical example are the fishtail morphology that you see here on the top right of the monitor, and the inverted chicken wing morphology. We need, with our pre-procedural planning, that has to be imaging-based, and we know that in most of the centers is still performed by utilizing transesophageal echo, not only to evaluate the LAA structure, but also to evaluate the surrounding structure. We need to record of any fluid into the pericardial space, to have a reliable comparison with the baseline in case of occurrence of pericardial effusion after the procedure. We need also to assist the mitral valve, especially if the patient underwent a previous surgical or percutaneous mitral valve repair and replacement. We need to evaluate the position of the pulmonary vein, the position of the Coumadin ridge, the relationship with the pulmonary artery and the distance between the pulmonary artery and the LAA structure. And we also need to have a look at the interatrial septum to see if there is some aneurysm, to see if it's too floppy or too stiff, and to identify the perfect site for the puncture and the crossing with our delivery system. Of course, we need to exclude the presence of thrombi in our LAA structure. Sometimes it is quite clear because they are very evident, like you see on the right of the slide, but sometimes it's not so easy, and our echocardiographer needs to find the right view to identify also poor represented thrombus in the very distal part of the left appendage, as you can see here on the left. What is another crucial step in the pre-procedural planning is the sizing of our LAA structure. Actually, we need to take 3 main measures that are the ostium, the landing zone, and the depth. And this measure needs to be taken at 0, 45, 90, and 135 degrees. But the way also how we measure and how we take this dimension is different with a different device that we may utilize. Why? Because as we have already seen, taking as example the 2 most utilized ones, the amulet and the Watchman device, they work creating a ceiling at the LAA structure utilizing completely different principle. And this is why with the amulet device, we need to measure the true ostium let's call it the anatomical ostium, that is this blue line on the left side of the slide. And then we have to go 10 millimeter in and measure the landing zone, and of course also the depth. In case we utilize the Watchman, we have to measure the ostium in a different way. I would measure here on the left the ostium going from where the circumflex artery appears to where the B letter is standing, and on the right in a different view, in this different view, probably just in the middle between the blue line and the yellow line. And I'm not a big fan of just taking measurement at the landing zone and at the anatomical ostium. These are three different illustrations of potential cases with which may deal, in which we have the exact dimension for the LAAO ostium and the LAAO landing zone, but we have three completely different shapes. If we take the one in the middle, that probably may be applied to most of the anatomy with which we deal, and we select, for example, an amulet 25 millimeter for this specific LAA structure. For the one on the right, I would probably go with a larger size device, let's say a 28 millimeter, just because the distal part of the left appendage is much more represented and may accommodate a larger lobe, a larger distal part of the device. Vice versa, if I have to size my device in the left structure in which there is a very narrow shape and the distal part is very poorly represented, I would probably select a smaller device size just to avoid a jump of the device back during the deployment, just because there is not enough distality. So it's not only a matter of measuring the landing zone and the anatomical ostium, but it's more like to have an idea of the wall dimension of the left appendage in different levels. And here we can understand why the transesophageal echo is not probably the most accurate way for the pre-procedural planning. Ideally, the CT scan should be performed in all our patients. We know that logistically this is not easy, but here you can see also if we take all the measurement in all the suggested view at 0, 45, 90, and 135 degree, we can miss the maximal diameter at both level, at the ostium level, at the landing zone level. So the CT is definitely most accurate for the LAA dimension measurements, but is not only important for that, it can really provide much more information. For example, if you see on the right, on the top right of the monitor, by analyzing the pre-procedural CT, we can identify the best, let's say, a fluoroscopic view in which we can implant our device. That is the fluoroscopic view in which we have the anatomical ostium and the landing zone in a line. They are not overlapped, and we can see also the distal development of the left appendage. At the same time, the CT can provide a three-dimensional overview and the orientation of different lobes. This is something that we cannot have with the transesophageal echo, but it can also suggest where is the best site to perform the transeptal puncture, the site that guarantee the perfect alignment with our delivery system for the deployment. And in case we are used to work with the CT fluoroscopy fusion, the pre-procedural CT can be utilized also for this. At the same time, there are different softwares that allowed us to simulate implantation of different devices, implantation of different sizes, and to evaluate the degree of compression of the device and the ceiling that we can reach with a specific device and the specific size. And this can help in selecting the best device and the best size for the specific anatomy of the patient. Coming back to the step-by-step procedure, I prefer always to perform an echo-guided puncture. I prefer also to utilize a single proglide like I do with all the transfemoral vein approaches procedure, being ready to administer half of the dosage of heparin soon after the position of the perclosure. And then after the advancement of the delivery system, it's important to identify the best site for the transeptal puncture. We know that is a general rule that the puncture needs to be inferior. This is true. And in most of the time, let's say 80–85% of the time, it needs to be posterior, but there are some situations in which it's better to have a slightly more anterior puncture, and this is especially true in morphology like the inverted chicken wing anatomy. In this specific case, the puncture was definitely inferior, was relatively posterior, but you can see here that there are some anatomy in which it's better to avoid the posterior puncture, and the typical example is the inverted chicken wing anatomy. Coming back to the case, here you can see in the angiographic view in the two ones that are usually considered the standard view, RO 30 degrees, cranial 20 degrees, RO 30 degrees, and caudal 20 degrees. We can see how our delivery system is well aligned with the ostium of the left appendage. In this case, the measurement, the landing zone was 21 millimeter, utilizing the fluoroscopy. In the same case, the landing zone utilized the transesophageal echo was quite similar. There was a very good concordance that we not always see. Here was around 22/24 millimeter, so it was not so elliptical as we typically see. And we decide to utilize an amulet device. I would also like to spend a few words about the basic of this device. So actually it has two components, a proximal disc. In the distal part we have a lobe. In the distal part of the lobe we have stabilization wires that actually help to anchor our device. And the lobe, when the device is implanted, tends to pull the disc, and the disc tends to pull the lobe, and this is how the device stability is actually achieved. In our case, the landing zone, there was a mean diameter of 23 millimeters. So you can see here, looking at the sizing chart, that the optimal device size for this case is a 28 millimeter, for which is 14 French delivery system is required. So mainly the size of the device is based according to the landing zone, not to the anatomical ostium, but of course we have to take in consideration also the anatomical ostium. And how this device is implanted, the amulet one that I prefer to utilize in this specific case. So when we are outside of the LAA structure, we have to advance the deliver, creating a ball. Then once the ball is created, we can advance our delivery system inside to the LAA structure, most of the time with a counterclockwise rotation to get better coaxiality with the left appendage. And then once we are at the landing zone level, we have to advance the system, advance the device. By advancing the device, most of the time the device does not advance, but just we create the lobe. And then we have to perform an unsheathing to release the disc and to push the disc against the anatomical ostium of the left appendage. And then the tag test is required to confirm the stability of the device. And here I was already in this case very well aligned, so I created lobe already inside the LAA structure. Then I pushed the device to create the lobe. Here you can see the lobe coming, and then I just deployed the disc by performing an unsheathing of the device. And you can see here angiographically with the injection of contrast, the final result without leaving any residual leak, and this patient was just discharged the day after the procedure. And you can also see here how is clear the compression of the lobe, and this is one of the main sign to get a good anchoring of the device. Other sign as the fact that we have a lobe that is at least 2/3 distal to the circ artery, the fact that we have an orientation of the lobe that is in line with the axis of the left appendage neck. We need to have a separation of the lobe and the disc has always have this elliptical shape that actually is the sign that is creating a ceiling at the level of the anatomical ostium. So I would like to conclude here my presentation, just summarizing the main concept. The imaging-based pre-procedural plan is definitely the key step to get a successful procedure. We know that the pre-procedural CT scan provides relevant advantages compared to work only with a transesophageal echo, but we have also to say that it's not necessary and still in most of the center is not routinely utilized in the pre-procedural planning. The transseptal puncture, of course, should be performed taking in consideration the LAAO morphology and its orientation, and if we cannot get a good alignment with our delivery system, we have to be ready also to reconsider to make the transseptal puncture in a different site. And of course, any device has its own characteristic. I mainly focus my presentation on the amulet that was presented in the case that I showed, and but there are many other devices, as we have already seen, and we have to know all the features of the device and all the related technical aspects. Thank you for your attention.
Thank you so much for your clear presentation. It is quite clear that this is a delicate operation, and of course it is necessary a very well preparation, as you said, very close cooperation of echocardiographer and the invasive guy, and also all the team has to know every detail of the operation and the anatomy of the structure.
Thank you very much for this presentation. Just a very quick question, because you know in the field there are a lot of devices coming out. For example, we had this CSI, we saw an Omega device. Do you think these devices will, by changing the behavior of the occluder, might facilitate the procedure, you know, position and all this stuff, you know, that so they're kind of self-alignment, you know, regardless of the angulation? What's your opinion?
Yeah, in regard to novel devices, I think that some of them are actually very similar to the two principal ones, especially the Omega, I think, is quite similar to the Amulet one. Probably in my clinical practice, sometimes in specific anatomy, I prefer to utilize device like Lambre, in which you may have special sizes, in which you have different sizes of the lobe and the disc, and you can easily anchor the device in anatomy that I would consider otherwise challenging with the, let's say, more common devices. So for your specific question, probably the Omega, I'm not sure that adds something more to the Amulet device, but other devices like Lambre with special dimension of the disc and the lobe can be useful in specific anatomies.
Thank you. Yes, there, Professor Kilic.
Hi, Francesco. I'm Theo.
Hi, Theo.
I want to ask a question, especially about the point that you mentioned about the transseptal puncture. The classical point is that the inferior posterior puncture, but in some kind of anatomies like reverse chicken wing, what will be your transseptal puncture point and that kind of reverse chicken wing anatomies?
Yeah, when I deal with these, let's say, not so common anatomies, in which probably the typical inferior posterior punction should not work, I always try in my hospital to perform also the CT, and then I try to identify the specific site of for the puncture by using the CT. When this is not possible because we work in real life, sometimes logistically it's also difficult to have the CT available before the procedure, or let's say that simply the patient do not have has some renal dysfunction and it's better to avoid also contrast injection. I always to try in this case to be not posterior, let's say relatively more anterior. Being ready if I'm not satisfied once I see the alignment of my delivery system, if I'm not satisfied eventually to, instead of trying to implant the device also if I'm not aligned, to do the puncture again. What I learned from some complications is that sometimes it's better if you try to deploy the device a couple of times, this doesn't work because you are not completely aligned to do the puncture again. But when it's possible, I always prefer in anatomies like the reverse chicken wing morphology to do the pre-procedural CT, and then to identify the right site for the puncture by analyzing the CT.
We have two more questions, I think. Kostas Kalogeras, Professor.
Thank you for the great presentation. Just a quick question regarding the way you assess any potential residual leak before you release the device. I understood, if I understood well, you assessed the leak by the angiography or the TOE, and how does it affect your further decision? Do you reposition the device? And how do you assess the severity of the leak? Is there an amount of leak that you say, okay, I will release it, or you want just no leak at all?
I don't know if you hear the question, Dr.
So let's say that maybe this was not clear in my presentation, but I always assess the final result before the deployment with both the angiographic injection and the transesophageal echo. But mainly, I'm guided in my decision to accept or not accept the final result by the transesophageal echo. Now we know, also looking at the data that have been just presented before my presentation, that also a minimal leak can be a problem for our patients. So we have always to try to get the optimal final results. Sometimes that's not possible, and it needs to be a balance between the risk of trying to deploy the device again and again, and the fact that you can accept it or not. I just had last week a very bad case in which there was a patient that previously underwent a mitral valve replay with mitral clip, and there was a residual regurgitation that was completely eccentric, directed exactly against the left appendage. So I tried to reposition my device 2-3 times, but finally there was nothing to do. I had to accept this not optimal good result because the jet was just against the LAAO and was just let's say behind the disc of the device. So I had to accept. Sometimes we need to accept the not optimal result.
I think we're going to proceed because I think for the sake of time, unless okay. So the next